and welcome to the launch of our second professional development series, this time focusing in on co-occurring disorders and how you can support and help support them via peer support. We have two incredible speakers today, presenters, Chacku Mathai and Dr. Jonathan Edwards. Between them, they have over 50 years of experience in the fields of mental health, substance use, and community engagement, from leadership roles at the local, national, even international level, to their many publications and impressive body of research, especially regarding recovery in peers. They have amassed a tremendous body of work as well as insights, and we look forward to learning and being inspired by them. We are looking forward to an impactful and engaging presentation. So there will be opportunities for you to chime in, whether that's on the chat or unmuting as we go along. Those will become evident. I just have a few more introductions and some housekeeping to do before we can begin. On the housekeeping side, please keep yourself muted if you're not talking to the whole group. And again, just a friendly reminder to introduce yourself, your role, and if you like, your organization as well, your organization's website in the chat box. We would not be able to have this series without the tremendous support and the expertise of the Opioid Response Network under SAMHSA and the phenomenal facilitators that they bring. We are also incredibly grateful for the ongoing support and collaboration from the Mental Health Empowerment Project and the Wellness Collaborative of New York. And a huge shout out and thank you to AHAC of Hudson Mohawk, who is supporting our expanded audience. Within 24 hours, we had 100 folks registered for this. So thank you again for your interest. And thank you once again to AHAC for your ongoing support and partnership and sponsoring the expanded audience. Without further ado, I'm going to introduce you to Catherine Cunningham from Horn, who will tell you a little bit about what they do, as well as information on continuing education credits. Catherine?
Thanks, Carrie. Hi, everybody. I'm Katie Cunningham. I am the Technology Transfer Specialist for the Opioid Response Network in Region 2, which covers New York and New Jersey. But we have a presence in all 50 states. The Opioid Response Network is funded through SAMHSA, and we assist states, communities, and local organizations such as Healthy Capital District and individuals address the opioid crisis. And the ORN provides training and technical assistance to support existing programs and expansion of implementation of evidence-based approaches across prevention, treatment, and recovery to address opioid and stimulant use disorders, as well as substance use disorders overall. So at our website, which is just opioidresponsenetwork.org, and I'll put some resources in the chat once I finish talking, we accept requests for education, training, program implementation and support, or virtually anything you can really think of. If you reach out to us, we can discuss what we can do to help you. And we provide experienced consultants in these areas to communities and organizations to help address anything related to substance use. So submitting a request to us is very easy. You can do it through our website. There's a big submit request button in the upper right-hand corner. And once you submit a request to us, we will reach back out to you within one business day and get a conversation started about how we can help. So I'll put all my contact information in the chat, and I'm excited to hear from Chacku and Jonathan. We are in for a really great presentation today. And thanks, Carrie, for setting all of this up.
Welcome, everybody. It's great to see you. And I'm excited to be joining Jonathan in this presentation with all of you. And as I look around the room, I'm even more excited because of the incredible amount of expertise I can see is in the room already. Some of you I've been able to work with and get to know. And while at the same time, there's a number of you that I haven't had a chance to work with and get to know. And so I hope this is the beginning of that relationship with us, and we can move all of this great work forward together. So I'm personally excited to be here in a number of ways. That's one of them, but also as a person myself in recovery, identifying with as a person with a co-occurring disorder history and experience. This work has been, personal and professional. And with that, I want to hand it over to Jonathan.
Thank you again, Chacku. And I'm also excited to be here. My name is Jonathan Edwards, and I'm here with an esteemed colleague I've known for nearly 20 years. I have the opportunity and privilege to draw from my own experience as well as my academic and professional training, to talk with you this afternoon about peer support for people with co-occurring disorders. And actually, I'm going to call that back and say co-occurring mental health and substance use, because we're always on a continuum of learning and language change. As a person with lived experience in both mental health and substance use, I know how important it is for practitioners, organizations, and systems to be attuned to the unique needs of people addressing both mental health and substance use. So integration is not 1+1. Integrated means one. And we're going to talk about some cross-cutting principles that are foundational to peer support for people with co-occurring mental health and substance use. Lastly, I consider myself a curious learner, which also includes teaching, training, and facilitating. And my skills, knowledge, and experience are always enhanced from participants of these forums. I'm really excited to look around and see so many faces. I see all the cameras on. Everyone has just shown up, and I'm sure you have a lot to share. And I'm really grateful we're not in the meeting format where we can't see you. So thank you. Chacku, I'm back over to you.
Thank you. Well said. Yeah. So as we think about these areas, and Jonathan, you raised a tremendous amount of perspective, even in just such a short time as you already just shared. I just want you to know that both Jonathan and I are bringing the experience of not just ourselves as individuals, but our and Jonathan, you mentioned our time in the movement together, and I think this idea that we're bringing the collective experience and knowledge to the best of our ability from all of our experiences, and hopefully will be resonating with yours. So we'd love to be able to tell you more about ourselves. There's a very limited amount of time in this training, so hopefully we'll be able to integrate a number of our stories and experience. But I've been grateful to be able to watch and be part of, Jonathan, your career in this process as well, and to see the incredible impact. And that's why I was glad to partner in this way, because the combination of actually implementing and integrating peer support in this process is a complicated one, and so that's why I'm looking forward to hearing what actually is part of your process there. But before we begin, I want to do something that's important to me, and I hope each of you have a chance to take away from it. But we're all likely participating on the ceded or unceded land of an indigenous people. And so for me, where I work, which is with Columbia and NISP and RFMH, is the Lenape homeland, otherwise known as Manhattan. Where I live, which is in Rochester, New York, the traditional territory of Haudenosaunee, and by honoring the sovereignty of the Six Nations here, which is the Mohawk, Cayuga, Onondaga, Oneida, Seneca, and Tuscarora. So I ask you all to join me and Jonathan in acknowledging all indigenous people and all ancestral and unceded lands of their people, their elders, both past and present, as well as future generations. And most of the institutions for which we work must also acknowledge that they were founded upon exclusions and erasures of many indigenous peoples. And this acknowledgement demonstrates, in a small way, our commitment to begin the process of working to dismantle the ongoing legacies of settler colonialism. And I also offer a labor acknowledgement. And this is where we must acknowledge that much of what we know of this country today, including its culture, economic growth, and development throughout history and across time, has been made possible by the labor of enslaved Africans and their descendants who suffered the horror of transatlantic trafficking of their people, chattel slavery, and Jim Crow. We are indebted to their labor and their sacrifice, and we must acknowledge the tremors of violence throughout the generations and the resulting impact that can be felt and witnessed today. So I share all of this without any forgetting of the impact of all of what I just mentioned in the development of our history as a system as well. We carry the same principles that often led and norms that led to the actual inequities that people are facing today in the system. So I'm hoping that all of our work will consider that and be a lens through which we consider how we accomplish peer support as well. So John, let me turn it over to you for the learning objectives.
Yeah, you're all going to hear me say thank you, Chacku, often, because in just sort of meditating on what you just shared, I was tremendously moved, and I feel tremendously grounded, that we're not just racing in to throw information at you or add things in without thinking about culture change, which is going to be one of the sort of themes in what we're talking about today. So for the learning objectives, they're written one way, but we really want to promote a conversational tone here. Here are some of the things we want to talk about today. I personally want you all to be inspired and want to remember some of the recovery principles that are cross-cutting that might support people with co-occurring mental health and substance use, as well as describe some of the benefits of peer support for people with co-occurring mental health and substance use, talking about some of the essential elements, and one of those is integration. I know Chacku talked about that earlier already, and also identifying specific barriers in your own organization's preparedness to integrate peer support for people with co-occurring mental health and substance use. We're not just adding peer support services here, or we're talking about that. We're looking to transform attitudes and practices. And I really appreciate that very, very salient parallel between grounding ourselves in a land and labor acknowledgement, as well as grounding ourselves in the awareness that there is many things that we can replicate, where we replicate harms in systems and in communities, and in this case, in treatment services. So if we can go to the next slide.
Ready for me to go in, Jen? John?
Yes.
All right. So we're hoping that those objectives align with yours in terms of why you chose to be here today. We'd love to focus on a couple areas, as Jonathan was talking about. One I'd like to start with, I just want to emphasize here that, our systems have tried to work together in mental health and substance use in order to address a number of needs, but the reality is it's been a tremendous failure in many ways. We've struggled with whether it's then at one time it was together, and then the systems were separated in order to better serve certain populations with the best intent. However, at the same time, every time we saw outcomes, the negative outcomes of homelessness, incarceration, suicide, these issues were clearly contributed to by the combined presence of substance use disorders and mental health disorders, resulting in very difficult, challenging, and disabling experiences for people. So what were the guidelines? Well, we said as a community, we said we need to start treating things together, not separately, not one thing first, not one thing after. We need to start being able to practice integrated treatment. So, and I bring that context because what ended up happening was even in that environment, and this is in some ways a difficult slide to picture, but what I want you to acknowledge or recognize here is that even with all of that effort, a lot of people still don't get care. And this is just in the context of treatment. Right, so just within the context of actual provision of clinical services for either mental health or substance use, things haven't gotten a whole lot better. And so this is why peer support oftentimes emerged in our communities. And I can speak personally from my own experience, was that it was one of the main drivers for why I got involved in peer support, was to create the peer support that wasn't available for me. Wherever I was going as a person with both mental health and substance use history, the system had a tendency to go, well, why don't you go over there for that mental health stuff when I was trying to talk about my substance use, or when I was talking about my mental health, they would say, well, that's another program that needs to be helping you. They couldn't somehow figure out how to support me. And I found the same thing was true in peer support. The peer support communities I was needed things to be separate. And so it was harder to find ways to build that. So we needed to build a lot of that on our own. And for me, this was, back in the mid 80s. And so I was finding myself navigating with systems and trying to, could we replicate what we were doing? No, I didn't want to do that. So the changes we pushed for oftentimes were also in legislation. And I want to just move through this very quickly. I won't have time to give you an overview on all of this, but this is even the most recent legislation in the last couple decades that focused on capacities like integrated care, which was Parity and Equity Act, for example, or the capacity to increase the level of support that was available for more people through the Patient Protection and Affordable Care Act, the 21st Century's Cures Act, specifically focused on inclusion of peer support, for example. However, in a way that didn't necessarily reflect what the peer specialist and support community would have actually advocated for, right? So there's a number of things, whether it's infrastructure, whether it's increased resources, whether it's a number of things like social determinant supports, which you'll find in some of the other, like the CARES Act and Appropriations Act and American Rescue Plan. These are all things that are moving us forward in good ways that we should look into. So I just wanted to call your attention to that. Jonathan, let me kick it back to you on recovery.
Thank you again. So in 2010, the Substance Abuse and Mental Health Services Administration, SAMHSA, convened a group of subject matter experts who were bringing their own experiences in substance use and mental health to the table to really talk about some of the cross-cutting principles that I talked about earlier, and to come up with a statement that sort of epitomized a working definition of recovery. And they've created this definition, which I'm going to read. Recovery is a process of change through which individuals improve their health and well-being, live a self-directed life, and strive to achieve their full potential. And so this was published a year later in 2011. And sort of accompanying this and breaking this out more, if we go to the next slide, we can see that there are 10 guiding principles of recovery. Many of these I know that you have heard of, you probably discuss with people that come to you for support and for treatment. You may even work these in your own lives. I know I certainly do, with HOPE being at the top of the list, and I didn't place it there. That's where the group did. HOPE comes first, but it starts with HOPE. And for me, that was a guiding principle before I even knew about recovery, because even when I didn't know that I had HOPE, I had HOPE. And it was always important for me to feel like I could make my own decisions, even if they weren't the decisions that you would have me make. And this was important in my own treatment, is to feel like my voice was going to be heard and was going to be counted. We know how important it is for a process to be person-driven, and also that there are many pathways to recovery. There's not one simple way of recovering, but people bring their cultural, their educational, their personal ideas, their dreams, their holistic practices, their spirituality. And that brings us and covers the holistic as well. And of course, we're talking about peer support today, that's certainly in the mix, and quite a major theme here, that it's relational, that guiding principles include culture, that they address trauma. Oftentimes I know early on I would always hear what's wrong, as opposed to someone asking me about what happened. And that guiding principles also are strengths-based and focus on personal responsibility. And most of all, need to be respectful. So there's a really nice pamphlet with the definition and these guiding principles, and we'll make sure that that's in the resources as well. Can we go to the next slide? And so the SAMHSA recovery construct really touches on, those 4 areas that I mentioned in the definition or alluded to, and that's health, home, community, and purpose. And each of these, have different implications, and, SAMHSA's portfolio of programs really supported both sort of the sustainability of many of these things. So with home, for example, we're talking about, someone's access to, permanent housing, and community, peers, the involvement of family, recovery network supports, for purpose, education, employment, and there's other areas that aren't listed there because purpose is self-defined. Those are just two of the areas that are commonly identified. And of course, health correlating directly with the recovery, and looking also at the importance of physical health and choice, and other resources that would support someone's health and promotion of recovery. Can we go to the next slide? And Chacku, we're back to you.
Yes, thank you, John. And so, along these lines, so let's think about, and I actually want to go back for the moment in this area, why we're talking about peer support for people with those of us who have co-occurring mental health and substance use conditions, and why we're talking about recovery. Of course, recovery was important in both the addiction recovery communities and mental health recovery communities. But when we came together in that conversation, what we were trying to do was, what's the construct we create so that people can see peer support and recovery supports across our communities and that are cross-cutting, as Jonathan said earlier. And these social determinants related to sense of purpose and home and the experience of what's going on in our communities and our neighborhoods, and what health means being self-defined, and what are the kinds of things that actually come out, were oftentimes a struggle to communicate to systems that were really just seeing us as people with disorders, as opposed to contextualizing our experience with the many social determinants that are impacting our lives. So whether that social determinant was racism and xenophobia, such as in my personal experience, or socioeconomic status, such as poverty and the conditions of the neighborhood, or the lack of social supports, or the level of isolation, or childhood adversaries, such as adverse childhood experiences studies that have been around for decades now, demonstrating a direct correlation between those adverse childhood experiences of loss, abuse, neglect, and household dysfunction with the chronic health conditions that people were having. So what we're suggesting here is, of course, treatment needs to do this, right, and recognize the interaction between social determinants of health conditions. But what we're trying to promote is a framework for peer support that recognizes and always recognizes these as cross-cutting priorities, that the conditions that we experience are experienced in the context of the social determinants we are experiencing. So that dynamic in peer support, we were able to be much more flexible around. So when somebody wanted to do something about their poverty, or talk about their poverty, or talk about the impact of racism, or talk about the struggles of oppression that they were going through, they could do that in a peer support context. Whereas the billing limitations, for example, of a treatment system, were oftentimes trying to decide where that fit and where that conversation could go. So a lot of times the peer support capacity to actually provide support before, during, after, or even in lieu of care or treatment was oftentimes because we were able to address social determinants. I'm going to keep going in that framework a little bit more. One of the things that you'll often hear people talking about is health equity. And I want to talk about it, what that means from the perspective of peer support. And that is that a lot of times when we think about health equity, we're talking about the outcome of everyone being able to experience high quality outcomes of recovery, right? I mean, we want equity for recovery equity. We don't want one group of people of color, for example, having a disproportionate higher prevalence in a certain area of the system, yet having the lower outcomes of rehospitalization, poverty, unemployment, that kind of thing, right? So the idea is to actually see those differences reverse. We want to see those change. We want to see, and that means that health equity is actually a process as much as it is an outcome. And so Dr. Jones's work really emphasized this, where she was emphasizing that if you don't create mechanisms that are the assurance of the conditions for optimal health, then you're going to be continuing to see those inequities not only happen, but increase. So what we're saying is peer support is actually one of those ways to assure the conditions for health equity. It is in and of itself a condition for optimal health by its very presence. So that's just something to consider. These are all, again, ways to frame how we're going to provide what we're calling an integrated peer support environment and support and setting and service across mental health and substance use. All right, give you an example. And Jonathan, how am I doing? Okay so far?
Yes, wonderful.
Okay,
Thank you.
great. So, and for all of you who are, looking at that recovery definition, I was in the room to help develop that recovery definition personally, and was very happy with how we came out with it. One of the areas, however, we struggled with was where to bring in this structural component that I was just finished talking about, the social, like it was such a centerpiece of our work as peer supporters to recognize the impact of social determinants on our lives, yet we somehow struggled with finding a way to make that explicit in the definition. So when we talk about recovery as a process of change through which individuals improve their health and well-being, live a self-directed life, and strive to achieve their full potential, even within a cultural lens, it tended to focus more on what that individual needed to change about him or herself or themselves, as opposed to recognizing that the process of change actually included changing the policies, social conditions, norms of the systems and communities around me. And if my peer support environment was not trying to pay attention to that, it wasn't serving me. If they weren't talking about the impact of the police in my neighborhood and how it made me feel, just the very presence of the police in my neighborhood or in my community was a deleterious effect on my health. Whereas the same person or another person in the same peer support group was saying they would call the police in a minute, where my family never called 911 because of that very point. So these recognitions of the impact of social policies and norms on the process of recovery need to be able to enter into an integrated peer support context. They can't be seen as outside the room issues or outside of the scope of the relationship or outside. So self-direction, yeah, it's informed by cultural norms as me as an individual, but self-direction and full potential are also concepts directly impacted about and by who's got their thumb on me, right? In other words, is force and coercion a part of the person's life or not? And how do I make sure I'm aware of the dynamic that force and coercion plays on whether I'm hearing a self-determined voice or whether I'm hearing the voice of compliance and looking for the voice of compliance. Because peer support is not about compliance. Peer support is about engagement. Engagement is not compliance. I know the sound of my voice in handcuffs, and I know the sound of my voice outside of handcuffs. They're very different. All right, now I'm excited to share that there is a new Office of Recovery that has been created by the Substance Abuse Mental Health Services Administration. We recently, over the summer, convened, I was part of facilitating this with Jonathan as well, convened over 200 people from mental health and substance use recovery communities. We had harm reduction communities. Director is Paolo Del Vecchio, who is a former CMHS director for SAMHSA as well. He's leading the office in a number of important areas. And in that summit, for example, there was conversations about how do we collaborate across mental health, substance use, and harm reduction advocacy communities? How do we have recovery and harm reduction as organizing principles for all of our communities to work, not just together in an advocacy frame, but also with peer support, right? How can these be the organizing frameworks for our peer support efforts? This Office of Recovery comes out of a call by President Biden's Unity Agenda to have a national implementation of peer services. So, of course, this is now never been a better time to really talk about integrating care and integrating peer support. And what does that really look like? Are we there completely yet? No, that's part of why we have this work to do. And so this presentation is not just a, here's how you do it from Jonathan and I, it's a call to action for us to work together to build it and to build it well across some of these ideas, and including, of course, justice, diversity, equity, and inclusion. Those were major themes in the summit discussion.
Chacku, can you
All
go
right,
back
Jonathan,
2 slides?
I'm sorry, go ahead.
No, can you go back 2 slides?
Yeah, of course. This
Yeah.
one?
Yeah, oh yeah, the one with the cultural and structural, the next
There
one.
you go.
Yes.
Yeah.
I first of all, that was amazing, just how you covered this, these last few slides. And, when you were talking here, I was waiting for a pause. I wanted to jump in and I said, no, I didn't want to break that wonderful flow you had.
Oh, sorry, go ahead. Yeah.
No, not at all. But I just wanted to say, this really resonates with me because, I wanted to scream out, the structural issues are not the macro issues that we'll get to later. And oftentimes that's what I heard. We'll get to that later. Your housing, if you lose your apartment, we're still going to work on your, psychological issues. And, I said something to the psychiatrist that I don't want to repeat here. And it wasn't a 4-letter word, but it was very much that, I really wanted a roof over my head while I was figuring out my issues. And so it was important to keep the issue of, housing, that larger structural piece in the conversation. And we can oftentimes, silo these concerns. And so I think this is a really, really important slide, to talk about that we can't get to the macro issues later. They are integrated, which is another interesting parallel is that, we really need to look at all these things together, just like we're looking at a person's mental health and substance use together. So that's all I wanted to say. We can go back to.
Okay, thank you. Well, it's all you now.
Yeah.
There you
Okay.
go.
So just, sort of riffing further on, the recovery principles that we've been talking about, in terms of having a vision for recovery across systems and communities. And once again, when we talk about, peer support for individuals with co-occurring mental health and substance use, and we talk about the system changes and system transformation that needs to occur, one of the messages that's really important to not just promote but to internalize and believe is that recovery can be expected. And I think one of the pitfalls is that when we define recovery for someone else, or we have a cookie cutter approach to how recovery should look, is that we can always say, well, the person didn't meet their goals, or, they're not really recovering. But recovery is something that is self-defined. And so we as practitioners and organizational leaders and, educators and trainers, we need to expect that recovery is the outcome for a person. And that in that, and Chacku just talked about some of these in the social determinants, is that there are always going to be barriers and obstacles. These have to be addressed. And I think I got a little ahead of myself because that's what I was talking about when I asked you to go back a couple of slides, is that we need to keep these issues, in the room and in the conversation. It's not just clinical treatment, but it's what's happening when the person leaves the treatment setting. As they say, how are you living, right? So second, recovery can flourish when the barriers and obstacles are addressed. Yes. We often lose sight that, a warm bed and a secure lock and a roof over the head and some nourishing food are just as important as the suggestion of someone, increasing their medication so they can cope better with substandard, supports, which should not be the case. We also uncover, abandon, and or develop new hopes and dreams. Oof. There's some letters after my name, but let me tell you all that, I was 40 when I completed my bachelor's degree. And, that became the driver for my recovery, because I was tired of weaving in and out of not just the mental health system, but the educational system. And so for me, I had abandoned that dream a few times, and it was really important for me to go back and finish. I didn't know that, some years later, I would have, some other initials after my name, because I'm a curious learner, as I said in the beginning. But it's really important for me to personalize this and talk about the importance. And it also helps me as a practitioner and as a program person to understand somebody else's hopes and dreams, and to work with individuals to encourage them, and to sort of walk alongside them in partializing the larger goal into smaller components. And then we also discover our personhood through our culture, our strengths, our values, and our skills. And our culture includes our spirituality. And we pointed to that earlier when we talked about the holistic approach to recovery. Strengths, values, and skills. I like graphic arts. A lot of people don't know that, but sometimes when I'm totally bored or even, burnt out, I may start designing something, and that's something that really brings me a lot of joy. It makes me feel total freedom, liberation. Earlier in my recovery process, when I was healing, one of the things I did, I wrote some poetry. I forgot that I had written it. I ran into it lately. I would design things. I would come up with logos. And so these are things that I did, to really enhance my own personhood. Even if I never became a professional graphic artist, it was important for me to be good enough for me. So this slide really does, it resonates with me personally. Let's go to the next one. We're going to continue. We recover together and engage communities as life-sustaining forces, and I think about mutual support and the peer support community, other communities of, coming together. I think about peer support as natural support, how peer support at its origin was non-monetized, it was non-hierarchical, it was voluntary. And interestingly, voluntary is one of the first principles of peer support, is that it should not ever be a service that someone mandates someone to, but something that's available to anyone who wants it. We reauthor the way that we see ourselves, and that's an ongoing process. And reauthoring is not a linear process. It is something that, sometimes we loop in and out of seeing ourselves in a way that's not so favorable versus, looking ahead and having a more healthy vision for ourselves as we would define it. Hope that's not a Zoom bomber. We also reclaim a meaningful life and roles. And, many of you probably understand that, whether it's through a friend, family members, people that you're working with in the system, and possibly yourselves. And we also give back to others what we have gained. And one of the 12-step mantras, I believe, is you can't keep it unless you give it away. So it's really important to play it forward, to give. And lastly, I just want to say, I think one of the pivotal points in my own personal recovery was understanding that if I were to judge my ability and likelihood to share based on my symptoms, that I would never be giving anything away or passing something along. And so I had to give myself permission to not condition my kindness or, my willingness to help someone else based on whether or not I felt well today. And sometimes feeling better and getting our steam back is by helping someone else, even if we're not feeling on top of the world. So let's move on. Okay, and Chacku, I'm not sure if this is you or me. Oh, it's me. Okay, so catalyzing the role of peer support. What jumps out for me on the slide is this concept of disruptive innovation. And it jumps out at me because one of our fellow peers, Dr. Patricia Deegan, who goes by Pat Deegan, who is also the author of something called Personal Medicine. She introduced this concept. I don't know if she invented it, but she introduced it as disruptive innovation is the role that peers play in changing the system. This is also an opportunity to say we're not just adding peers to a system, but we're really looking at how to transform systems of care. Disruptive innovation is a way of disrupting the injustices, oppressive practices, microaggressions that have been inherent in the system for a very, very long time. And so, peer supporters, when knowledgeable about advocacy, when feeling empowered enough, when feeling, on good footing, are really the change agents that bring about disruptive innovation, and not just changing the way that practices happen, but changing the way that organizational culture looks. And I think I covered the next one by saying it's not simply adding, peer support services to the existing system. That's sort of, I was trying to think of a metaphor, but I can't. But Chacku and I were talking the other night about, you can add the sink, but if you don't have the plumbing, then it's ineffectual. And basically, we're not just adding peer support service, but we're including and we're integrating and we're weaving in. Also centering lived experience at every level, which sometimes means that, the champions, the people at the top of the organizational ladder begin to feel more comfortable talking about, their own trials or experiences. Once again, not a requirement, but this is just something that tends to level the playing field and help people realize that having lived experience and being successful are not mutually exclusive. In fact, I don't know that they ever are. Racial equity and inclusion, which was covered on the last slide, and harm reduction. We can't say enough about harm reduction as we know it now, both in substance use services as well as mental health. We have to be able to talk about harm reduction as one might experience it on either side of the equation in the same statement. That someone might be, hearing voices, someone may choose to do something that we term self-injurious in order to bring comfort to themselves, or perhaps not to inflict that on someone else. So we really have to learn about harm reduction principles and how that looks in a person's recovery. Chacku, I think I'm passing back to you.
Yes, you are. Thank you very much, Jonathan. And so, as we're talking, I want to go over harm reduction specifically a little bit more, as Jonathan was just describing it. Each of the things, and just again, as a reminder, each of the things we're bringing up, and if you've noticed, we're not suggesting in order to integrate peer support that suddenly we have to train on specific illnesses and symptoms and conditions. That's what you're noticing us talk about, is we need to increase training on cross-cutting principles like recovery and the values. So we need to emphasize social determinants of health. We need to emphasize issues of racial equity and inclusion. We need to emphasize the principles that actually call upon peer support to be a role in the changing of a system. So the role definition of a peer supporter for those of us with co-occurring mental health and substance use conditions is one that actually includes change agent responsibilities. All right, so it's not like that's not my job, or being told by a supervisor, hey, why are you asking for change? That's not your job. Your job is to go help that person over there. Well, guess what? I am. I'm trying to do that right now. Now, in harm reduction, a very similar dynamic was occurring. So I guess I'm bringing that up because it's the same dynamic around people who are seen as kind of in the harm reduction community, advocating for a change in which a lot of times even the recovery community was having a hard time embracing, which was simply to meet people where they were at without an agenda. Now, when all your training is motivational interviewing, it's hard to not have an agenda.
How do you?
Right? So if the fundamental tenet of motivational interviewing is to honor the expertise of the person, that you can work with. Right? So you can say, what is the expertise that a person is bringing, even if it's something that I'm having a hard time understanding. Like, Jonathan, you mentioned Hearing Voices. I'm a member of a community called the Hearing Voices Network. We have peer support meetings all around the country, internationally, actually, and in our own community. And our very approach is a harm reduction approach, which recognizes that we all make meaning of our experiences in very different ways. And the way in which we understand we need to help each other understand how we make meaning of those experiences. Culture in and of itself is meaning making. So that process of calling for the non-judgmental, non-coercive provision of services and resources is simply just that, not having the agenda. In harm reduction, we ensure that people have a voice, just as Jonathan was talking about peer support having a voice and change. We're helping people lift up a voice that may have been pushed down over and over and over again. So in peer support, we actually, we can kind of ID that, you know, we can see, oh, this is someone who's struggling with something that I've struggled with, who's speaking up, you know? And why, just because I ask them what their goals are or what their skills are or what their strengths are, doesn't mean they're going to come out and tell me right away. I need to build trust. I need to build a relationship within the context of that process, and that a real voice, remember the voice of sound of my voice in handcuffs? That's not my real voice. My real voice is the voice that, like Jonathan said, you know, I really want to get that degree. I want to pursue something that represents who I am, you know? So, I'm sorry, was somebody trying to say something? All right, I'm just going to keep going. All right, I apologize. I'm not able to see maybe, you know, where the hand. We're going to give some room for comments shortly. You know, a couple other points around this, and again, I want to emphasize harm reduction. Well, a lot of times the writing is specifically around drug use. We're adding experiences of mental health as well to this, and we want you to, you know, kind of keep that in mind, that it's not necessarily the cessation of drug use, or not necessarily the cessation or the stopping of a mental health symptom as the criteria for successful policy or the criteria for successful intervention. Peer support has always recognized that we can have struggles and be doing well, you know, based on my self-directed idea of what doing well means, you know. Right. I've just been through a lot of struggles myself, just like many others have. I had somebody come up to me earlier when we were advocating around a law called Daniel's Law, where we're, you know, wanting non-police police intervention, for example, in New York State. And in Daniel's Law, we're calling for peer support and an EMT, not clinical support, not MSWs, not, you know, social workers. And, you know, I was presenting to a social worker crowd right, about that. And I said, don't take this personally, but we want you to recognize the value of lived experience in these situations. And a social worker came up to me afterwards. Yeah, you know, I agree with you. But and I said, I feel a but coming. And she said, yeah, I agree with you, but, you know, peer supporters are great, but, you know, they have a lot of stuff going on. And I said, oh, well, yeah, that's true. We do. But you're saying that as if you don't have a lot of stuff going on. And is that true? And she said, no, that's not true. I said, okay, well, I think social workers, we're all from a humanizing experience, recognizing that we're all dealing with a multifaceted phenomenon that encompasses a whole continuum of behaviors and experiences. And this is a chance for everyone to kind of relate, you know, across a variety of different experiences, but the pluralism can come through a harm reduction framework. So anyway, I guess I'm preaching to the choir probably here about this, but you know, the idea is that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, a number of social inequalities, these are the kinds of things that affect someone's vulnerability and capacity to deal effectively with their challenges, whether it's drug-related harms or mental health symptoms or, you know, whatever it is that you're seeing in front of you. So that's the idea. Can we have a harm reduction approach that is seen as an organizing principle for engagement in both mental health and substance use? Can we use that as a way to challenge the existing silos in our systems and practice models? You're going to have to take a look at the certification programs that we have, because our current ones are set up in different systems, right? We have the SERPA, we have the peer specialist certifications. We have a number of different models. And in this training series, you're going to meet people and others that, you know, we've specified certain population groups in those certifications. And that's one approach. But I also don't want to forget the cross-cutting principles that Jonathan and I are presenting on here. Even when you do a special population certification, that these principles are going to be important for effective implementation and integration. Jonathan, did you want to take this, or am I taking this one?
Well, according to my notes, you are. Well, I think we
Okay.
are in a way.
Okay.
Yeah, right.
Well, I mean, there's a resource that is worth pointing out, you know, and giving a whole slide to, right? And which is that And I was a part of promoting this by Alterum and BJA. It's a peer recovery support services in correctional settings, and but the idea behind what was done there in this particular project was that it helped organizations and anyone trying to implement. So if I've been a CEO, I've been an administrator, now a number of different ways in which I've supported the development of peer support. And it's important to kind of pull out what are the essential elements for integrating peer support? What are the design factors? What are the drivers of success? What are the integration processes? These are all laid out in this manual, in this particular publication. So just check that out and you'll see a number of details that we want to make sure you know. Now, Jonathan and I are going to talk about some of them, but I really wanted to point that out. All right, Jonathan.
If we can go back, Chacku, and just drop the share.
Yeah, good.
Yeah. So I know that was a lot of information, a lot of personal experience woven in, and this is all about personal experience when you talk about it, when you think about it. What we want to do now is really just, find out from you, what were some of the key takeaways from, what you've heard as practitioners or administrators. And if you can put some in the chat, or I can look at the participant list. If you want to raise your hand, we'll call on you. And I think that happens in the order in which the hand is raised. So please reflect for a moment and let us know what are some of the key takeaways from the information that you learned today. David.
Yeah, wow, this has been it's been encouraging, it's been enlightening. I believe it's brought me to another level of thinking about peer support. I'm a peer advocate, residence advocate at the Capital District YMCA with men. And one of the things that I took away from this was, and this is the encouraging part of it, was in one of the slides, I just, what I took from it, and I don't remember exactly what it said, but peer support disrupts negativity or bad lifestyles, bad choices. It disrupts a bad lifestyle. I'm not sure if I want to use bad, but and is a catalyst for change. Am I you probably know what slide I'm talking about. Does that sound like a proper interpretation?
Definitely.
Okay. That right there is really encouraging, because it helps me to understand that I'm in the right type of industry. And so that's just one thing. I wrote a ton of notes, but I just wanted to express that.
Jonathan, you mind if I respond for a minute?
Please.
Yeah, so first of all, David, I was going to respond to a comment you made at the beginning before, as people were coming in, and I think you said, I don't feel like an outsider anymore. And I resonated with that because, my mantra, and walking into every room, including this one, was, I don't belong here. I mean, that's the first thing I would say. And then as soon as I thought it and felt it, I would start looking for evidence of it, and I would find it. Sometimes it was easier than others, and sometimes it was harder, but I would find it, and that's what I cooked, And what I wasn't realizing in those situations, and someone in a peer support context helped me reminded me of this, was that my very presence was a disruption. But it was also a disruption that was needed.
Yeah.
And that's the part that I was missing, that I couldn't figure out why my difference was such a hard time for everybody. When someone said, no, that's what we need, Chacku. We need to, you might be feeling it was Pamina Yellowbird that told me this, actually. And she said, your power is in your difference.
Mm.
You're experiencing your difference as marginalization, and that's true too, and oppression, and that's true too, she said. But when we experience our differences as power, we can actually leverage it and do something with it. And that's what we're calling upon in peer support. So anyway, that's it. Thanks.
Wow.
Yeah, and I would say that there's definitely correlation between what we might feel as resistance or intolerance to ourselves and the significance of our presence as a disruption. So, Dean, you're up.
Thank you. So actually, I think I'm going to dovetail again into what Chacku just said. So first, he remarked about the social worker, and so let's just look at where we fit into everything. We have psychiatrists, we have clinical psychologists, and we have social workers who have all gone to college and been told that they are good at what they do now because they have a college degree. And what I want everybody to realize is that as a peer, we are good because of what we have. Now, I am, so I'm the director of the Warren Washington Rose House here in Glens Falls. We're part of People USA, which is primarily in the lower Hudson Valley. So before I became a peer and before I got healthy, I did marketing, I did sales, I was working for large non-for-profits. And, but it was because I was unhealthy that things weren't good. So here in the Rose House, what we say to each other, and a lot of you out there might understand this, when people get healthy, they immediately, when they start to feel better, they want to help other people. But what we say here, if you haven't done the work, you can't do the work. And that's the thing about peers, is if you want to be a peer, you have to be willing to share your story. And you can't share it effectively unless you have really worked on yourself and are comfortable in your own skin. And so, yes, so the social worker said we have things going on. I think more of us have less going on than people who have never addressed it. So, thank you.
So, Dean, I'm putting in the chat one of my takeaways, and I'm quoting it. And if you haven't done the work, and I have a typo there, you can't do the work. So I got one of my important takeaways from you. Thank you for that. Thank you for that.
Yeah, that's what we say when a new staff member comes in, and probably everybody here in peer services, you almost know within 2 or 3 weeks whether or not this is going to be a good fit for them.
So for those of you who haven't heard about the Rose House, there's there's a model that the Rose House was one of the first in New York. It was the first in New York State. It was a peer-run crisis respite model, and the respite started actually in New Hampshire in stepping stones in the early 90s. And the idea was that we could support each other through very difficult crises and not have to go back to hospital. And our alternative there was an important one. And so thank you for that. And I think this idea that we, in peer support especially, I think that this is one of the things that I try to make sure that we're avoiding is any, judgment about, where someone's struggles are and what they can bring. So in other words, the ability to do the work on myself and that create that self-reflection is what I'm looking for from people. And I'm actually looking for from psychiatrists and social workers and substance use counselors and people who may not necessarily identify with lived experience too. I think that's just as important. Anyway, thank you.
All right, so we're going to hear from Kay. And David, is your hand up again, or is it up from before? I didn't want to I'll lower it then. I just didn't want to do that without your permission. So Kay, we're ready for you.
Hi, everyone. My name is Kay. So I have a lot of thoughts. This is a great presentation so far, by the way. I am someone who is both a person in recovery, in long-term recovery, and a social worker. So I have both of those hats. And what I have seen, what I've seen in organizations that has made it challenging is that there are actually a lot of people who are mental health counselors or substance social workers who are in recovery, but certain organizations that they work for may have a policy, you can't say anything, you can't be honest about that, divulge that. I was fortunate, I'm currently not in the field. My children are very challenging and I'm in fitness right now, but I was at a mental health substance abuse treatment facility for years. And I was fortunate to work for a place where that was seen as an asset. You know, I was able to be open about the fact that I was in recovery, and it had a tremendous impact on the clients that I worked with. They loved that, that they really could hear in my voice when I said we, like we're in this together, I meant we, you know, and I think that's kind of one of the hurdles, is that there's still like this hierarchy of like us versus them type thing. And that's what I remember from, you know, when I was in active addiction, going to treatment and stuff, you know, I didn't want to feel any more stigmatized or any more separate. So it resonated with me when people were like, well, I was where you were, but I got my, you know, I got my life back on track. I'm in recovery. I got sober. I did all these things. And it gives you hope too, that you can see yourself doing those things in the future. So I don't know if there's just a way that for more just like honesty and professionalism, that, you know, there isn't such a divide between, you know, the professionals versus the patients, because a lot of people suffer with things, but they feel they can't, you know, and obviously there's a time and a place to talk about your own personal experiences. But I think just in general, structurally, and from a systems perspective, it's still that kind of model, you know, where we're separate and we're really not. There's a lot of, you know, professionals who have that lived experience with mental health or substance abuse. That's all I got. Thank you.
Thank you so much, Kay. You know, one of the things I used to share with people I provided supervision for was the use of just judicious disclosure. I don't think I was judicious today. I think I was rather flowing, but you know, sort of sharing things in service of helping someone else to not feel so alone. And it's such a delicate dance, because, you know, many of us, and not necessarily in this room, but many of us in life are recovering. And so, you know, when we work with others and talk with others, we're drawing from our own well. And as this gentleman said earlier, you know, you can't do the work if you haven't done the work. And I don't know that the work is ever over. And I used to want the work to be over, and now I hope it never ends, because the work keeps me on my toes. So thank you. And yeah, go ahead, Chuck.
Jonathan, around that. Yeah, this is an important point that Kay, you're raising. Thank you. And you spoke about it. You know, really, you know, I think your observations are right on. Like, so just from a data perspective, you know, in the 80s and so forth, when I was first talking about emerging in as a person in recovery and being an advocate, a lot of the disclosure at that time by substance use counselors was very actually open, you know, so just to use that's part of the system. It was 80% of, you know, substance use counselors were actually disclosing actively or more. Then as the KSAC and other kinds of professionalized roles started to become more explicit, there was a desire to reduce that self-disclosure. And part of it was not just really the exact self-disclosure itself, but it was closer to what Jonathan was talking about. The criteria for self-disclosure wasn't clear to people around that. They think that peer supporters are just sharing whatever, you know, just making it about ourselves and centering ourselves in every conversation or something. And that's not at all what's happening, right? There's a relevance, there's a criteria for the impact of it. There's a recognition of whether there's going to be harm involved. There's a lot of actual training and consciousness involved in self-disclosure in peer support. Now, the reality was by 2000, that number went from 80% to 20%. And then, as you said, in some organizations, 0, because those organizations actually had policies that said you don't disclose here, which I found really valuable to challenge. So becoming a peer supporter in those environments or became the only way to self-disclose. And that created a culture disruption that wasn't effective for people who was like, you know what, there is actually some benefit for me saying I like the color blue, or having pictures of my children in my office, or having a human person experience and having somebody get to know me as a person, as opposed to just a clinician with no personal experiences. So I imagine that we have a long way to go in terms of what clinical supervision looks like around that, but I think that's something worth being more explicit about and being an advocate around. So anyway, thank you for that. I'm sorry, Jonathan, if you want to take too much time, but I also think this is what we were hoping for, which is this kind of a dialogue. This is really exciting. Thank you.
Yeah, I wish we were in a physical room together, because I
Yeah.
know it would, we'd have refreshments and everything. But anyway, we're going to hear from James, and then I want to sort of share some of what's in the chat. We got some really great,
Great.
great responses there. Go ahead, James. Thank you for your patience.
Thank you.
James, can you unmute yourself?
Yeah, can
Yeah, we got you now.
you hear me now?
Yes.
Okay, great. Thank you. I want to say thank you to you guys and everybody in the room for your input. Yeah, I was kind of thinking about how I've worked in the field for probably about 6 years now. And I've worked in peer centers, I've worked in hospitals with clinicians, and I feel like the one common theme I seem to run across in terms of barriers of system seems to be the understanding of clinicians to what a peer's role is. It seems like there's a lot of explaining that has to be done for them to understand what our role is. And I feel like I've had, at least for me personally, I've had instances where I will explain what I do, and yet there is no follow through, as if I was perhaps another sort of clinician, that they seem to understand the relevance of, like, a peer's observation. Okay, so, little background, like, I am, a person who's in long-term recovery. I work as a peer. I went to school for KSAC. But my heart's in peer. That's more what I relate to. I like it. And it just kind of seems like there's like a miscommunication, some type of, I don't know, maybe it's just because we're kind of new in our, peers being in the workforce, with treatment teams. Maybe it's just because it's a new thing. But that just seems to be a general observation I've seen in multiple locations. So I don't know if anybody can relate to that, but that's just my 2 cents.
Oh, thank you very much.
So I just hope it gets better over time.
Thank you again. Rebecca in the chat said that disruptive innovation and catalyst for system change are 2 takeaways, and that you saved the slides. So you're going to have 2 slides, because we're going to give you all the slides and you have your own screenshot. So you've got double the knowledge there. Forrest says, and it's not just my power, but it's my superpower. Wow. And then there's my takeaway. And then Sam, or struggling to see, Sam or Sammy. Sorry, I can't make that
That's
out.
okay. It's actually Sami, but everyone gets it wrong.
Sami, though.
Sami.
Well, thank you.
Yeah.
Okay. So you want to read it now that you're off mute? Go ahead, read your own. Usual.
I'm not sure where I was a little bit active in there.
I say share it only when you feel it is an advantage to circumstances. Yeah. It can be counterproductive,
in my opinion.
Yeah.
See, it has to, it depends on the situation, and you can kind of feel when it is or not. And of course, don't get into like war stories and get too in depth of what, you know what I mean? So, but depending on what the person is and what you're feeling out from how they are, you got to kind of conform to,
Counterproductive, countertransference, right? So, then we have another one here. If you don't work on self, how can I be hopeful to someone else? Yeah. We have another one from Karen. Okay, so Karen says that this workshop really attacks the educational elitism that exists, while at the same time we acknowledge there are those who have not worked on themselves to work. There is no screening for that when it comes time for employment in this field. And Karen, did you want to say more about that?
Good afternoon. I'll just be brief. I think what strikes me here is unhealthy whether you're educated or experienced. and that health has to be emotionally healthy and spiritually healthy in order to help anyone else. And I think I work in an environment that, that is very professionally oriented. And what strikes me, and other staff that are actually on this Zoom today, is that it doesn't take into account the actual wellness of any one of the individuals on that team and that group of individuals. And it tickles me in a way that we don't screen for wellness. And in this field, I've worked with professionals that were not well as recovering folks that were not well. And I think so the dividing line isn't really education and experience. The dividing line really seems to me to be about health and being well. Thank you for letting me share.
Oh, you're very welcome. And David, you raised your hand.
Yes, there was a part, it's under the slide may have been labeled as health and recovery equity. And it was stating, it was talking about understanding the different, or maybe this is what I took from it, I'm not sure, but I wrote down understanding the difference between cultures. Now, this, how do we, it's a question, I guess, how do we combine this understanding of the differences between cultures? Like, give me an example or scenario. How do we combine this understanding of culture differences to help health and recovery equity? That's the main thing, because equity is one thing, and then understanding the cultures is another thing, right? What are some examples of combining, to have equity? What do we, some examples of how to I don't know, like combining the understanding with, you know what I'm saying?
Jonathan, I'm happy to respond to the question.
Yeah, please.
We were still doing some takeaways. So there's a few more in the chat that we'll definitely want to get to. So a couple of things, and I think this is relating to a thought that I was having as other people were talking about, how to maybe hire for wellness in a more effective way. There's a couple issues. One is to speak to your question. That slide was really about the distinction between a definition of recovery that really focuses on what I as an individual need to be able to do in order to support my recovery. And that's informed by a number of things, including culture, right? So like the pathways I choose might be different based, my family practiced yoga more than they would support using medication, for example, right? So that was a pathway choice. We have Ayurveda in my family versus other types of healthcare. So those were pathway choices that were driven by culture. The structural definition that what I was trying to emphasize there from an equity perspective is the recognition that oftentimes people are not being understood from the perspective of how the environment and the social determinants are impacting their lives. So they oftentimes would in the system talk about me as running away or paranoid or overly delusional about people constantly monitoring me and following me around. However, when you really looked at what was actually happening to me, that's exactly what was going on. So it was a judgment about my own health and wellness based on how I was showing up from a kind of symptom perspective, individual symptom perspective, without necessarily understanding the social context. Now, what does that have to do with health equity? Well, it means that a lot of times people are not able to, when you don't address those social determinants in terms of how policing or other kinds of things affect a person's choices, right? Now that person only has a limited number of choices. Now I don't get to go to the same recovery center that everybody else goes to because they call the cops there.
Got it. That's what I was assuming.
So now I'm not going to go there because your recovery center calls the cops as soon as somebody gets a little mad. I'd rather go over here where they'll talk with me, help de-escalate what's going on, and not just de-escalate me, but actually work with whatever was making me upset in the first place. So that's one thought. The other thought I wanted to just offer, just people were talking about, speaking of equity, is that there's a reason why we don't measure people's wellness for employment. I just wanted to point that out. It's called employment discrimination. Before the Americans with Disabilities Act was passed, many of us were unable to even get employment supports, much less be considered employable. Before we focused on things like ban the box, we couldn't have any type of employment without somebody looking at our arrest history. So the reality is that there's a lot of judgment about who gets to work and who doesn't. I had a case manager that decided whether I could work or not. When I was trying to get help for employment, they gave me a dishwasher job when I said, no, I wanted a different job. I'm not saying there's nothing wrong with being a dishwasher. That's not what I was practicing interviewing for.
Yeah.
In this program. So there's a lot of different issues there, but the more important point is that the operational competency that we need in our whole workforce is self-reflection and the ability to reflect on those. And you can interview for self-reflection. I did that a lot. You can interview for people's reflection on their lived experience, about their stories of overcoming but what we aren't looking for is, the interview question is, tell me about your mental health history and let me see if your story is what I'm looking for people to hear. That's not the interview question in peer support. All right. Anyway, thank you.
Thank you.
One of the interview questions I used to ask is, what are some of the things about your what are some of the lessons that you feel can connect with people that you'll be talking with? So it's not saying well, what exactly happened, or what meds you're taking, or what was your diagnosis, but what have you gleaned from your journey that you feel will help you connect with others? I think that's a way of drawing out a person's reflection.
Yeah, and to connect with that, Dot, think about it. If you marry the framework that Jonathan and I just finished presenting on, their answers reflect not just an individual, like, here's what I did for my recovery, and therefore other people need to do that too. It's a reflection on social determinants, a reflection on recovery values. It's a reflection on multiple pathways. There's a lot of different things you can look for in this framework to have an integrated approach. Anyway.
We were getting a lot of comments, and I can't tell really like which ones might have been takeaways or just other I guess wisdom that people are sharing. And I'm if you can save the chat, save it, because there's a lot of good statements and wisdom here.
I wanted to point out Deb Rhodes' comment about the history, because Deb, you've been around that time I was talking about, and those are the CACs, the Certified Alcoholism Counselors in particular, right? That before it became CASAC, your comment was that back in the day really acted as peer support, right? And that's what I observed as well. A lot of the people involved at that time were people who started the first detoxes, that started the first programs that were actually available for treatment support. And a lot of it, because it came out of people who had a history of 12-step, for example, there was a lot of tension around that in the professionalization process. So you're saying it was the only way people in recovery could give back in a professional way. And I think our clinicians are struggling to understand the peer role more. I wanted to ask you if you had any thoughts, but you wanted to share about that.
Yeah, I just, sort of to, echo what I think it was James was talking about. I think that not only clinicians that are in the field that may not be in recovery, but for those who are in recovery, the peer movement, I think, has really been challenging, especially for folks who have been working in the field a long time. They're what I've heard from staff is that, well, how is this different? Right? I've been doing this for this many years, in this role? And why can't I self-disclose anymore? Right? I mean, all of those issues that have come up and I think have made it difficult for peers to integrate in some settings, right? I think we've come, a little bit further along, but I think there's still a lot of work to do.
Thank you, Deb. Jonathan, there was a question in there they wanted to also lift up, if you're okay with that. It was, Hella, in terms of meeting people where they're at, any advice on how we do that if their lived experiences are very different than ours? Great question. What can we do to better familiarize ourselves with circumstances that are simply outside of our understanding? Any thoughts on that, Jonathan?
I remember we used to talk about cultural competence, which is a term that I think, we're not using so much anymore because I think it was widely understood. One of the things that I did like about that term was it was defined for me as always maintaining the asking stance. So having that sense of, and I think maybe it also gets a cultural humility, just sort of, being willing to show up for someone and help them doesn't mean that we're the expert on their lives. And, it really is disrespectful to start guessing and presuming about what someone else's experience is. And I think it's important to ask people to tell you or to share if it's something that they're comfortable doing. And hopefully that people's experiences would be very different from yours or mine. And, as I said, it's an opportunity for us to learn. And part of healing is the ability to tell one's own story. So asking someone about something that I don't know about, but they're looking for me to support them, I need to get educated on, help me to help you, and I think that is, one of the mantras that I would probably apply if something is totally outside the realm. Help me help you.
I think that's such an important point, Jonathan. I mean, think about that when I am actually more comfortable with what I know, that's when I'm most likely to fail in my peer support process. If I go into this like I know exactly what you've been through, I hope you never hear a peer supporter say that, because none of us can know exactly what another person has been through. What we can know is a way to reflect on our own experience and how we make meaning out of that, and ask somebody, wow, with the curiosity that Jonathan was just talking about, right? I wonder what that must have been like for you. Can you say more about that? I wonder what you mean by that. Can you say more about that? I'm curious how you, I'm blown away how you made it through that. Can you tell me more about that? There's actually much more that can be accomplished when we don't know than we can when we do know. And that's an explicit principle of peer support.
And there's your takeaway.
In terms of the role clarity and the integration and onboarding, that's part of the whole impetus for this series and why we recorded and sent out the materials as well, in hopes that you'll share it with your org. I think that the term peer is so often referred to in so many different ways. So people say, oh, I already have peers. And they're talking about, like, a fellow colleague, or peer-to-peer student work, or peer navigators who are helping folks navigate their health insurance or their health care. So I think that the integration and onboarding is just so key, and all of you showing up and attending and sharing your experiences also are just so invaluable. Thank you, Chacku and Jonathan, for just your invaluable materials and insights. I was writing nonstop and quoting, and I look forward to continuing these conversations and the series, as well as sending everyone out the materials. Just wanted to note that in the chat, I just repasted the information for New York State in terms of certification, training, and ongoing professional development, but there'll be plenty more to come. So for closing remarks, Jonathan or Chacku, please feel free.
Yeah, go ahead, Jonathan. Yeah.
So it's been great being here. And, there are times during, these types of sessions when it's like, oh God, when is it over? And this one, I'm saying, like, we only have 3 minutes left, so you've all been great. And, true to my vision is that, I learned so much and I'm even more inspired. Chacku, I know we had like some takeaways that, they'll be in the slides, and if it's okay with you, maybe we can just let it stand with what we heard from each other and let people look at the slides later. And, we just had a few extras, but yours are just really wonderful. So, with that, I'll sort of turn it over to someone that I consider a mentor, and I really enjoyed training with. So Chacku, it's all yours.
Oh, thank you, Jonathan. Well, right back at you. I've learned a lot and enjoyed training with you as well. So, and with all of you, I think, if there are takeaways that I'd really like to emphasize are, if you're going to focus on implementing a peer support model that is going to include a focus on people with co-occurring mental health and substance use conditions, don't forget all that we know about recovery principles and harm reduction principles as a way to guide that process. Like, that is your guide. And everything we've taught, if you're going to make a choice between training on illnesses or conditions versus training on recovery principles and harm reduction principles and the practices of peer support that are cross-cutting across community and the way that we do social determinants of health and all of those areas, choose those trainings. People can look on WebMD all they want for other stuff, right? You don't have to worry about that as much. And people can learn about their individual conditions from each other anyway. So I think that's kind of the biggest thing that I was hoping, to get across, is that there's a real opportunity for our system to really learn from this, all the things that you're doing. So don't forget to see the value in that.
We are at our time limit. I'll leave the chat open for a little bit more in case people want to be able to copy, paste, communicate, etc. I will also be copying the information on the chat and sending out things that are relevant to the folks, especially those of you who have shared your willingness to share either your role or contact information or your organization. Otherwise, I hope that we will see you in 2 weeks. The registration information is in the chat, as well as you should have received it. For those of you yearning to be in person, we are having a community health conversation on March 23rd at Conifer Park from 9 a.m. to 10:30, which is focused on substance use disorder. We want to hear from everybody. So whether that's yourself who's in recovery, or you're a community member where substances have affected your lives or others, or you're a provider, a peer, etc. We hope that you will attend that. All of our information can be found at Eventbrite Healthy Capital District. You have my information in email, so please feel free to reach out anytime. Thank you all again so much for attending today and for the fantastic life-saving work that you're doing. Take care all.
Bye.
Take care, everyone.